All right, everybody. Today we have we're going to go with Cole. We're going to go with Cole instead of Robert. We have Cole Perringer on. He was last year the resident in addiction at the Twin Cities at the U, and also is toxicology fellowship trained. So he's going to talk today on methamphetamine use disorder and bupe management. So that's today's little talk.
We tried to hire him, but he had to go with the ever famous Beth Bilden.
Yeah,
we can't blame him for that. I would have done that too.
We'll get him sooner or later. Okay. Announcements. Remember, there's free CME, so please answer those emails when you get them, so you get the free CME. If there's other people in your room, please let us know so they get credit.
Videos are always appreciated, and if you have questions that come up throughout, please chat them in. We'll interrupt Cole if we find them pertinent at that exact moment. Otherwise, we can help facilitate the questions at the end. Coming up, the Tuesday Echo. You grabbed your own clipboard.
Just keep going.
Oh my gosh. He needs help organizing. So the final Tuesday Echo is in a couple weeks. It's going to kind of be a wrap up everything that people had questions on after the fact. Next week on this Echo, we have the people from NIH and NIDA. That's an update on data? No, I don't even remember.
Yeah, well, it's Dr. Einstein. So we're the first Echo in Minnesota to have Einstein on. So.
Right. And then, so you can kind of see what's coming up through there. And then, of course, Sam Quinone is November 2nd. Do not miss this. This is an absolute must. So the author of Dreamland and The Least of Us, we're trying to finalize exactly what he's talking about and all of that. His only request was that at least you've started a book so you have a little understanding of what these books are about. And today just happens to be Buy It Book Day. So it worked out perfectly. Yes. Kurt even bought the book.
I bought the book.
He's almost read an entire book.
It's absolutely disturbing. Dreamland is. It's disturbing.
Oh, and really quickly, the next week is on meth overdose deaths among American Indian and Alaska Native populations. So very pertinent to a lot of things, of course.
All right. Remember, if you need some technical assistance, maybe we should tell them to call Cole. You can always give us a call, and our numbers are here. Aaron's number, if you need something, or our cell phone numbers are also listed. So please feel free to give us a ring.
All right, the online resource guide. Yes, I promised everybody the manual. I know some of you asked me specifically about the ER one. The ER part is actually done. I just need to get it somewhere. We are going to have the manual published here very soon. We're almost done with the very last section. We're finalizing the policy section of the manual. We have to send it to our good friends at MDH to give their final sign-off blessings. But it's
also going to be disturbing because we're going to put Beth Bilden's phone number in there so you can call her too.
In the manual.
Yeah. We're going to put that in there.
All right. The Weekly Addiction Connection podcast. My life is crazy. I have 4 kids beginning of school, a lot of soccer. That's my excuse. But basically, we didn't post one yesterday. We are going to tape it tomorrow and post one, and then we'll try to get back on track.
Yeah. We're going to do something other than sugar addiction, which clearly is
we
not
have a
an
couple
addiction.
more and love them. Okay, so with all of that rambling, Cole, we already kind of half introduced you, Kurt did. We will let you share your slides and take it away.
Yeah, maybe tell people what you're doing now that you're all grown up.
As of Monday, what you will be doing.
Okay, my name's Cole Perringer. I'll be starting at Essentia Health on Monday, where I'll be doing 75% toxicology and addiction. Mostly inpatient and 25% hospitalist. So I'm excited and just finished my fellowships down in the Twin Cities. All right, can everyone hear me?
Yes.
Perfectly.
Okay. All right, so I'm going to be speaking about methamphetamine use disorder and buprenorphine management. So these are the objectives: to discuss the epidemiology of methamphetamine use disorder and opioid co-use, briefly review literature on use of medications for opiate use disorder as pharmacotherapy for co-occurring meth use disorder and opiate use disorder, and then to discuss our approach disorder with a focus on those who have co-occurring opiate use disorder. So first, I'm going to discuss a little bit about the epidemiology. So methamphetamine, as most of you all know, is a potent and highly addictive stimulant. It can lead to profound psychological, medical, social consequences. In some areas of the country, it poses an even greater risk than opioid. And it is, as you guys also know, one of the drugs that most frequently is related to violent crime. So beyond its devastating effects on individual health, misuse can also threaten whole communities. So we get new ways of crime, unemployment, child neglect. We get infections like HIV, HPV, or HCV. So a little bit on the epidemiology. In 2020, approximately 24,000 people died from an overdose involving meth. In those aged 12 and over, approximately 1% reported using meth, while half those reported methamphetamine use disorder. 0.2% of 8th to 12th graders reported using meth. And one of the most alarming statistics I came across is that since 2016, methamphetamine use disorders, and overdoses have all more than doubled each year. So this is a busy graph that I basically put on to show that methamphetamine use usually does not occur alone. There is frequently other substance use or serious mental illness that happens along with it. So what I want to emphasize in this slide is that opioid co-use is increasingly common, and the red arrows point to heroin and prescription opioids that are other substances that are often misused with methamphetamine. So methamphetamine is increasingly used with, substituted for, or contaminated with opioids. It provides or is thought to provide synergistic euphoria, or just used as a substitute. Meth use is increasing with people who misuse opioids, people who are admitted for opioid treatment, and in at-risk populations. The resurgence of meth use in the past decade has been termed the twin epidemic. In the twin epidemic comprises psychostimulants and opioids. Since 2017, over 50% of meth overdose deaths have involved opioids. This has been called the fourth wave of the opioid epidemic and includes fentanyl analogs and methamphetamine. So this is a figure about showing the national drug-involved overdose deaths by specific category from 1999 to 2020. I just want to highlight the psychostimulants with abuse potential, which is now, as of 2020, is number 2 on this list. So taking a closer look at this is the overdose deaths involving psychostimulants with abuse potential by opioid involvement. And this is over the same time frame. And in the blue bar graphs, you see all psychostimulants. And with the yellow line, you see psychostimulants in combination with synthetic opioids. And then in the gray line, we see psychostimulants without any opioid. And then I've just kind of blown up 2017 through 2020. So since 2014, the number of deaths involving psychostimulants have risen significantly each year. Cocaine, too, has increased steadily since 2014, and almost 20,000 deaths were reported in 2020. So the purpose of this is a study by Havens et al., and their purpose was to examine longitudinal changes in methamphetamine use in people who use drugs in Appalachian, Kentucky. They looked at 8 waves of data from 2008 to 2020, and they compared recent injection, what they refer to as NMPO, or non-medical prescription opioid use, and injection methamphetamine use, and they looked at those over time. So in this cohort, injection of methamphetamine significantly increased over time. And with the blue bars, we have non-medical prescription opioids, and in the orange bars, we have methamphetamine. On the x-axis, we have these waves over basically time. As you can see, methamphetamine eventually overtook NMPO as the injection drug of choice. These results are just one of many studies that support the notion of a twin epidemic. So this is a graph many of you have already probably seen that shows admissions to SUD treatment. And one thing to keep in mind is that in the United States, only 1 in 10 people with a substance use disorder receive treatment. And this just shows that from 2011 to 2019, methamphetamine use is increasingly what is the reason for admissions to SUD treatment. You have the drop off in 2020 as an anomaly because of the COVID-19 pandemic. So now I'm going to briefly review the scant literature on the use of medications for opiate use disorder as pharmacotherapy for co-occurring meth use disorder and opiate use disorder. Again, there's not a ton of literature, but I'm going to do my best to summarize it. So this is a retrospective study that evaluated the effect of methamphetamine use on treatment retention among patients receiving buprenorphine for opiate use disorder. So they looked at 3 SUD treatment programs in the state of Washington. The self-reported meth use at baseline in these programs was about 30%. What they found was a twofold relative hazard for non-retention in treatment, which basically means that non-retention was over 2 times more likely in those that were using methamphetamine. And that the more methamphetamine they were using, the more likely they were to be non-retained. So on the left part of the slide, we see a Kaplan-Meier curve for methamphetamine users and non-users. Methamphetamine users, you see the red line, and the number here is around 770. On the right, we see estimates of hazard ratios for non-retention associated with methamphetamine use at baseline. And this is within the past 30 days. Again, the more methamphetamine they use, the more likely they're to be non-retained in treatment. So this is a study that looked at naltrexone's effects on methamphetamine use. So 30 participants, and it's kind of a cool study. 30 participants completed 2 4-day medication regimens. They either received oral naltrexone, 50 milligrams, or placebo. These were all randomized and double-blinded. On day 4 of each medication regimen, participants completed 2 things. 1, a Q reactivity paradigm, and this was to assess for degree of cravings. And this was followed by intravenous administration of methamphetamine. And this was to assess subjective responses. So each of these figures looks at the positive subjective effects of IV methamphetamine administration. And you can see the question at the top of each of these graphs, like how stimulated do you feel? How high are you? On the x-axis of each of these graphs is the MAUQ, Q-induced craving score, which is basically a score that assesses for degree of cravings. The higher the number as we go from left to right, the higher the craving. On the y-axis, we have the model-adjusted drug effect questionnaire scores. And these were estimated at 10 minutes post-infusion of methamphetamine, as we discussed earlier. This assesses the subjective experience. Each line corresponds to the 2 arms. The naltrexone administration corresponds to the red line, and the placebo conditions correspond to the black or gray or black line. As you can see, the Q-induced cravings for meth was positively associated with positive post-infusion subjective meth effects. So what are these positive post-subjective effects? Things like stimulation, quote, good effects, that they feel the drug, that they feel high. They also found, or concluded, I should say, that naltrexone versus placebo significantly reduced the association between Q-induced craving and positive subjective response to methamphetamine. So this is a retrospective study examining the impact of methamphetamine on opiate use disorder treatment retention. And this is in subjects that were prescribed buprenorphine, or the combined buprenorphine naloxone or Suboxone versus naltrexone and extended release naltrexone. So buprenorphine versus naltrexone. And what they found is that naltrexone, those who received naltrexone, you can see this in the graph on the left, had a 3 times higher dropout rate for those who used methamphetamine. And so on the right-hand side, you see the buprenorphine, combined buprenorphine and naloxone graph, and their retention was essentially the same, regardless of whether they used methamphetamine or not. So this is a study, double-blind randomized controlled trial that examining whether buprenorphine decreased methamphetamine cravings, and this is 40 adult men undergoing SUD treatment. They found that buprenorphine augmentation at 6 milligrams per day, and this is in comparison to placebo, significantly reduced meth cravings and use during treatment. And by looking at the graph, you see the time on the x-axis, and on the y-axis, the mean CCQ. CCQ is cocaine craving questionnaire, just another means of assessing degree of cravings. And as you can see with the buprenorphine plot, significantly reduced cravings. I cannot explain why it suddenly jumps up after 16 weeks. So this is a double-blind randomized controlled trial of methadone versus buprenorphine in the treatment of methamphetamine withdrawal cravings over a 17-day treatment period. This is also in 40 male subjects. So on the blue line, you can see methadone, and the green line, buprenorphine, y-axis cravings, x-axis time in days. There's a significant decrease with buprenorphine compared to methadone, but this is not large, just a small change. So like I said, there's not a ton of literature. So this is the summary of some of the studies that I evaluated. Meth use is common in opiate use disorder treatment, and that as retention rate decreases as meth use increases. Naltrexone significantly decreases stimulant cravings and use. And then a number of things regarding buprenorphine. That buprenorphine increases the retention rate compared to naltrexone and extended release naltrexone. And this is for those individuals using methamphetamine in opiate use disorder treatment. That buprenorphine significantly decreases meth cravings and use, and that it also decreases meth cravings compared to methadone, but not by a whole lot. So this is a study that came out a few months earlier this year / few months ago, termed the dopamine supersensitivity theory. It's a novel hypothesis of opioid-induced neurobiological mechanisms underlying opioid stimulant co-use and opioid relapse. And I thought it's if you have time to go over, I think it's a fascinating read. It basically provides a mechanistic basis for why those individuals who are dependent upon opioids have a much higher risk of developing dependence or use of stimulants, methamphetamine in particular, and provides a really elaborate mechanistic basis. But it dependence the corticolimbic dopamine system, and that the severity of these changes to the length chronicity of exposure. Opioid withdrawal leads to a state of substantial dopamine deficit, which we all know, and that one of the things that they kind of outline is it's long after the somatic and observed all have resolved. And then dopamine develops soon after opioid use, an increased response to dopamine agonists. It's mediated by changes in the sensitivity of D2 receptors. This leads to increased stimulant sensitivity, particularly in stimulant naive or inexperienced populations. And surmise that stimulants are uniquely reinforcing to persons with this cravings or motivation to use that prompt opioid relapse and withdrawal. now going to try kind of change directions and talk about treatment of stimulant use disorder and treatment of stimulant use disorder and my approach to it, or my approach to it during fellowship, which I just completed. So of note, to start, these are pharmacotherapies. So importantly, there is no FDA-approved pharmacotherapy for stimulant use disorder. In addition, there is minimal or insufficient evidence to suggest any particular pharmacotherapy. However, myself and many others still regularly prescribe pharmacotherapy for stimulant use disorder. So this is a table that I created, and I'm saying I because it's my interpretation of the literature, and so it's mostly for your reference if interested. Of note, there is more literature and older literature focusing on treatments of cocaine use disorder rather than methamphetamine use disorder. This is changing as meth use increases. This begs the question, can we extrapolate cocaine literature to methamphetamine use literature? I want to emphasize, and I don't know the answer to that. I want to emphasize that the literature supporting stimulant pharmacotherapy is poor, and that any benefit from pharmacotherapy is usually small and may not be sustained. So the table's kind of busy again, mostly for your reference. So going to kind of go over some examples of how I apply this. So pharmacotherapy in the setting of stimulant use disorder alone. And as I'll discuss later, briefly just mentioned, this is always in addition to whatever you have for psychosocial behavioral therapy. So pharmacotherapy, stimulant use disorder alone, if it's just methamphetamine use, I think the most robust evidence in the literature exists for the use of naltrexone, plus or minus bupropion. I don't feel strongly is my number one choice. My number two choice would actually be topiramate. And my number three choice, which I've never actually prescribed just for methamphetamine use, but given the literature and potentially in a few years, maybe the use of buprenorphine for the treatment of stimulant methamphetamine use disorder. For just cocaine use disorder, my number one choice based upon the literature is topiramate. My number two choice based upon the literature is disulfiram, which I've never actually prescribed for cocaine use disorder. The theory behind disulfiram, which is kind of odd, is that it does inhibit dopamine beta hydroxylase, which is the enzyme that converts dopamine to norepinephrine. So theoretically, and has been shown in some literature to decrease cocaine use, as you can see in my table, and then possibly buprenorphine. So in a nutshell, my approach to pharmacotherapy is guided basically by other substance use and psychiatric comorbidities, as we saw in some of the earlier slides, which are very common in the setting of methamphetamine use. So again, other substance use, psychiatric comorbidities guide my therapy. So some examples. So on the left, top left, we have methamphetamine use disorder alone, which we've already gone over. And what about the approach if they have opiate use disorder or on other agonist therapy? My recommendation would be buprenorphine. If they need something in addition to that, it's plus or minus topiramate. My number two choice, if they're unwilling to do buprenorphine, would be any other medication for opiate use disorder, whether it's methadone, etc. But buprenorphine, given the evidence we went over, would be my number one. If it methamphetamine use with problematic alcohol use, my choices would be first, and again, this is based upon the literature, or my interpretation of the literature, naltrexone. Number two choice would be topiramate. And number three choice would be disulfiram. Almost always 1 and 2 are sufficient. If there's high risk sexual behavior, naltrexone or topiramate. And there's some evidence that mirtazapine might be helpful in this situation. If there's other sedative or hypnotics, I think there's evidence for naltrexone or topiramate. And if there's opiate use disorder and alcohol use disorder, my approach is buprenorphine, again, for focusing on treatment of the opiate use disorder, plus or minus topiramate is something else is needed for focusing on pharmacotherapy for alcohol use. Number 2 choice would be other medication for opiate use disorder. So what if they have certain psychiatric comorbidities? If they have depression, I might be more apt to use mirtazapine or absolutely use another antidepressant in addition to whatever I choose. If they have bipolar or a psychotic disorder, which frequently accompanies meth use, then close supervision and close monitoring, because they're at high risk for decompensation, particularly for the use of stimulant or methamphetamine with an underlying primary psychotic disorder. ADHD, I've done this in a few patients, and I think that evidence is not strong, and I think a lot more research needs to be done, but I think it's reasonable to consider a low-dose, long-acting stimulant. And I guess in regards to my fellowship, this was definitely pursued in some people I trained under, or this treatment. And if there's the presence of insomnia, I'd be more apt to choose gabapentin or mirtazapine. So this is kind of a summary of methamphetamine use with opiate use disorder. If it's just methamphetamine use disorder alone, naltrexone and topiramate. If there's a presence of opiate use disorder, my number 1 would be buprenorphine plus or minus topiramate. And then problematic alcohol use with opiate use and methamphetamine, again, going to target opioid use over alcohol use with buprenorphine plus or minus topiramate. So I won't go over the purpose of this talk is not to go over psychosocial behavioral treatments for stimulants, but I do want to note that any intervention or interpersonal dynamic therapy is no intervention at all, and that's with pharmacotherapy. And there's pretty robust evidence for this in the literature. And then another thing is other risk management or harm reduction, social services connection, facilitating the access to safer materials, a syringe service program, supervised consumption spaces. Again, this isn't the purpose of this talk, but probably some of the most important things that you can do for your patient. Emphasizing the importance of nutrition, hydration, and sleep, to take breaks during their use, safer sex. And so some of my these are my take-home points. First, that there is minimal or insufficient evidence to suggest any one particular pharmacotherapy for methamphetamine use disorder, that specific medications are guided by other substance use and psychiatric comorbidities, but we frequently still do, and I should say I and others frequently still do prescribe pharmacotherapy, consider naltrexone or topiramate. There is increasing evidence and rationale for the use of buprenorphine as pharmacotherapy for co-occurring opiate use disorder with methamphetamine use disorder. And then obviously strongly encourage risk management and psychotherapy. And with that, I'll open it up to any questions.
Oh, there's plenty.
I'll stay in my paper. Really quickly, as far as talking about the buprenorphine, just kind of assuming, but just for clarification, are you using buprenorphine or buprenorphine naloxone combo, like the combo or the mono product typically?
Whatever their insurance will cover. I'm under the strong belief, mostly from a pharmacologic perspective, that the naloxone is not going to have a big effect is not going to have any effect. So whatever their insurance will cover.
Yeah, and there was actually a question regarding insurance. Like if you're prescribing somebody who has clearly just a methamphetamine use disorder, what's the way you're going to get insurance to pay for buprenorphine for that? Is that possible?
I first off, I have never actually prescribed buprenorphine yet just for methamphetamine or a stimulant use disorder. It's only been for stimulant with opiate use disorder. And I do not know how to, that's a great question that I don't know how to get around.
Yeah.
Yeah, I had a cocaine patient, primary drug, would use heroin like every 2 to 3 months or so. And I did use Suboxone in that patient, and it actually worked very well, but insurance paid for it because I could say mild opioid use disorder because there was heroin involved every once in a while. But let's see. I don't want to go there yet.
All right,
You go for it.
Did Beth have a question?
I asked that question.
Okay.
I think.
So what my other question would be is when we look at using naltrexone
Bupropion.
in these patients, are you using it oral or have you used it injectable for methamphetamine?
Whatever they're willing to do. I would prefer the injectable, but whatever their social circumstances enable. I guess I would personally prefer the injectable over PO, and I don't think there's any literature to support one or the other at this point. And then regarding bupropion, I haven't seen my limited experience, and I don't think the literature supports that. So there's that big New England Journal of Medicine study on bupropion and naltrexone, and at least my interpretation of that study is that in those individuals where bupropion was not used, like the bupropion had a very small, if any, effect on the benefit that naltrexone showed in that study. And so I'm not convinced, based upon the literature, and definitely not in my brief experience, that bupropion is even necessary, that the that they're on is naltrexone, despite, yeah.
And having spent a year in corrections, it was kind of one of those meds we stay away from, just
For the misuse.
depending on the patient
Yep.
and everything there. So, Charlie.
Hi, great talk, Cole. This is awesome. One quick thing is that I think,
Hey, Charlie.
hey, we're coming up to Superior Hiking Trail in a couple days. We'll wave as we're driving by. A couple things, like I think it might be a little hard to get intramuscular naltrexone paid for methamphetamines. I don't know, but I think alcohol,
Sounds good.
you can get it paid for alcohol, but IM naltrexone for meth might be tough. But then the other thing is, I've been doing, you just react to this, people who are methamphetamine only users, and then have an accidental fentanyl overdose, and they're not tolerant to opioids, they don't seek opioids, they're just accidentally exposed to opioids. I've really been pushing naltrexone hard, and this sounds terrible, but I've even been saying things like, hey, if you might use meth, take a naltrexone first. It might lower your cravings, but it'll certainly help offset the risk of another fentanyl overdose. So it's like a harm reduction approach to naltrexone, and or like naltrexone for alcohol use disorder, the Sinclair method, like that same concept, except for methamphetamines. And people seem to buy it. I mean, they're like, oh, so I can just take this before I use meth and I won't have another opioid overdose. And I know that's not as intended, but I don't know, react to that strategy.
So those would be the patients who are not primary opioid people, just the people who are getting inadvertent opioids, just to clarify.
Right. And I'm just saying, take it right before you use meth, and it might protect you from an opioid overdose.
Yeah.
I really like that idea, Charlie. I think that's a really cool idea. Yeah.
Yeah, and I think that it does play into what we see a lot, because, I've had many people with methamphetamine, and I don't know, I guess this kind of leads into my question, Cole, is, what you have seen in using topiramate and naltrexone, and I use more topiramate. I've just really used quite a bit of topiramate, and what you think of the response is from a percentage standpoint for patients. Because in my world, I guess I feel like about 50% of the time I get a reasonably good response with methamphetamine patients. Do you have a thought?
I don't have nearly the experience that you do, Kurt. In my few patients that I've done or seen with this, at least subjectively, I see a response. I don't know whether it's actually stopped them from using, but it seems they report that it helps. I would say, roughly a half, I guess.
Yeah.
But again, that's small n.
Do you have special codes? There was a question in here about, prior auths, or how do you get that topiramate covered when we're talking meth use?
I am not the best person to answer this. I've never actually been in practice for myself yet. So this is all with my attending physician. So I don't know the answer to this question. Any help would be appreciated.
Yeah, I mean, it's interesting because I've written for quite a bit for meth and for alcohol. I've never had it rejected once.
That you're aware of, or Brittany might have just taken care of it for you.
Yeah, I mean, maybe my nurse fixed it, but I've just never had that be a problem for either. So for some reason it is going through. I don't know if Charlie, if you have an experience that way as well. Same?
Yeah. Look at that. He agreed with you. Okay, I do have a question. Because I don't say my automatic go-to for meth use disorder, but going through patients' mental health history and just their history in general, that wasn't on your list, is the patients with high ACE scores, high PTSD, chronic PTSD, all of those things. If that's the case, I go to Lamictal first every single time. Mm-hmm. And I know one of the other providers, she's not on here right now, in a different health system on her own, actually did the same thing too. And I have had ridiculous success with that. Now, that's not my go-to if a person doesn't have a lot of trauma and they're using meth, or they have, their ACE scores, negative 100, then I will go topiramate first. But this is one of those things, there's not a lot of studies out there, but if you happen to come across that or have seen it, or comments.
That's fascinating. I have not come across it, but I have also not come across a lot of these patients in general with that. So I think that's fascinating.
I could type my doses of Lamictal.
Yeah, what do you use?
So I do 25 milligrams once a day for 2 weeks, then 50 once a day for 2 weeks, then 100 once a day for 2 weeks, and then I stop at 150. I usually see him back in the 4 to 6 week mark, and it's fascinating. Every once in a while, I'll go to 200. I only have a couple patients on 200. Everybody else, if it's going to work, it's working by 150. And I think a lot of it is when, you mentioned it with the whole psychosocial and just all of that intervention is really helping them not have that fight or flight response, or they're not so extreme. That was what meth did. It helped them cope with everything in their life. And that was just how they didn't have to deal with it. And so asking those questions, and, the Topamax or the Lamictal, I'm always saying, instead of giving you here to here, we're going to bring you here to here. Whereas the normal person might be a little bit more there. And that has been effective.
Yeah. It's interesting. Cole, have you had much, what you've seen in the literature as far as the doses of topiramate for meth as opposed to alcohol?
What I've seen is a little bit lower doses, like usually around 300 milligrams. But I haven't seen studies that show the same, improved response as the doses of topiramate get higher, but this litter is also pretty scant on it. So I think it might very well be the same in 5 years.
Yeah, it's funny because, if you look at a lot of the studies with alcohol, they were right around 200 or 300 milligrams. And, I don't know, I have typically hung around, 100 twice a day or even 100. And if people get a response, I kind of hold. I mean, I'm a big believer in more is often not better, but yeah, it's interesting. I don't know if there's much out there. It's the difference between meth and alcohol as far as dosing. But I start low too. I started 20 and 25 BID, then 50 BID and 100 BID. And that's usually where I kind of reassess, but.
Kurt, I'm actually very similar. I don't know when to, sometimes I'll go up to, depending on like how severe the use is, I might go up to 300 just based on the couple studies, and they just randomly use 300. But I usually stick around, actually that's the same, almost identical dosing I use.
And I don't know if it's kind of semantics, but when you're looking through those studies that have, the higher the meth amount, the much, how do they quantify all this meth in all these studies that you're kind of coming up with? Because, I think that could be helpful in a way as far as like who to watch more closely as far as patients. But I mean, again, semantics, it doesn't change much. I was just curious more how they.
A lot of it, I think, I'm trying to think back to particulars. I think most of it was self-reported. In those particular studies, it was self-reported.
Kind of with that, have you seen in any of that, like the timeline of how long the buprenorphine, like if they have co-opioid use and methamphetamine use disorder and they're on Suboxone, they're on buprenorphine product, is there ever a waning effect of the impact on the meth? So let's say a couple years in, they're doing really well opioids. Does the meth ever kind of come back? Like that just doesn't have that same effect, or is it not, or does it just kind of stay at bay?
Ooh, that's a good question. I don't know if I can answer that.
I mean, I'm assuming the studies just haven't been done yet.
Yeah. I definitely didn't come across a study that could answer that. But yeah, just from a mechanistic basis, I don't know. I could think up reasons for both, I guess.
Right.
Yeah, when I looked at some of the stuff that's really with topiramate, the amount of, and some of these other drugs for these things, it is really scant. I mean,
yeah,
really,
it is.
Yeah. So,
yeah. It would also be interesting.
It's not good.
Be interesting, and this is not out there either. If, a person gets to a point in their opioid use disorder and they have stabilized and discontinue the buprenorphine, or you have those patients who want to start buprenorphine and then taper off kind of to get them just tapered off and do abstinence based, how that impacts their long-term meth use, or if it's more impacted by the social where they have developed in their lives, versus chemical imbalance, if you will.
Yeah. I'm curious from the audience and you guys in general, like what your experience with buprenorphine and with co-occurring meth use or stimulant use and opiate use disorder and those around buprenorphine. I guess in my, again, not a huge end, but I have seen a very good response to both methamphetamine use and opiate use disorder with buprenorphine.
Thoughts?
I'll be a bit of a skeptic in a way and say, I mean, of my buprenorphine patients, the ones who use meth go right on ahead and keep using meth despite being on buprenorphine. I have a lot of buprenorphine patients who are still using meth, and we talk about it every time. Now, what I think the benefit is, they keep coming back and they're willing to talk about it.
Yeah.
And they're willing to work on it. So it hasn't totally spiraled out of control. But so maybe the buprenorphine helps them moderate enough to continue to engage or something like that. But it's not like they're getting abstinent. They're some do, but they're struggling still with meth.
I think that's a good point. And I think that's kind of the whole question of, should you kick a person off of their buprenorphine if they're using meth? I mean, it seems like such an old thing to even have to talk about, but that still happens where a person's still using meth, and so they get their Suboxone taken away. Whereas I think Charlie's right, it's just kind of that re-engagement. And I think there maybe is potentially a placebo effect there. If you kind of build the patient, like my patient with cocaine use with very, very, very infrequent heroin, his cocaine use went away, and He wasn't obviously injecting that. And so it was crazy. I don't know if it was more of a placebo effect or if it was what it was, but it worked. So anybody?
This is a little bit hard to formulate, but Charlie's talking from a specialty perspective and from a primary care perspective, where if what we're doing is not leading to abstinence, we're supposed to refer on, which, a lot of people have already gone through it 6 times, and that's not going to help. And if they have a good rapport with me, they're probably better off staying with me. And there's also a risk mitigation part of this as well. If you can keep them on bupe, even if they use meth, the meth has fentanyl in it. And if you can keep them from dying of an overdose, in the big picture, that seems to be a benefit. But I get a little squeamish about, somebody getting audited or something and saying, well, why this guy had positive meth, why are you still treating him?
I think those days are probably over, and the fact that I don't think anyone's gonna bat their eyes at you anymore. I think a couple of years ago people might have questioned that. And you're exactly right, Dave. I think you should keep these patients, even if they have that meth use. And the reason is like they're comfortable with you. They've obviously gone through a lot with you. If anyone's going to be able to continue those conversations, like Charlie said, it's going to be you that's going to hit that impact.
And I think too,
it does fly in the face of our controlled substance agreement, where we say, you got to abstain.
We changed that line, so very soon you'll get all the new papers. We changed that line completely.
Are you doing kind of okay? Because yes, we'll continue your medicine.
And for me, it's more about the trust and relationship. So I say, I'm not going to give you a strike if I walk in the room, I've got your urine. If you tell me, hey, I did this, it's a foul tip, not a strike.
Yeah, and I think too, one of the things when we started doing this years ago, when we get patients still using meth and we just follow along, we were always kind of looking for, what can we add on that might help? And that's when some of these studies and different things with Topiramate and other meds kind of started coming out. And it's nice now that we can, it's like, okay, they're still using that. Let's add this, let's try this. And so I always look at it as a work in progress, right? It's like, every time you meet with them, it's like, hey man, what's the deal here? How's this working? Do you want to try something else? Maybe we can make the cravings less of a problem. And, but yeah, it sure changed. How we feel about it.
Yeah, it's a big paradigm shift, but it has not gone out to general primary care for sure.
Or to treatment facilities.
Yeah.
Even. We run into that with treatment facilities. Jails, which you'd expect them to be behind, but they're on buprenorphine going in and totally like with the program, they have meth and they're done. And, it's hard. For me, it's that conversation of, okay, what happened? Why are we using the meth? Did something happen? Or did you just hang out with these people? Like, let's think about it. But I don't know, the harm reduction thing, especially with fentanyl out there, it's just.
Yeah. Go ahead.
Yeah, I think the other big issue unstated about continuing to treat someone who is actively using meth is there may be some behavioral issues in the lobby. Other patients might notice this person, or the front desk might notice this person, and you got to kind of have a plan for that. And that might be challenging as well for a clinic. So that can be a barrier.
Yeah. Other questions? Anybody else? That's a good discussion.
It was a great discussion. I think it's just one of those things that it's a lot of great information, a lot of new things. A couple of years ago, there was just like, we don't have any meds. Good luck.
Yeah.
Contingency management was the only thing that even kind of had anything behind it. And to do that in primary care is like, good luck. And so it's bringing up these although not super strong, overly in-depth studied things, it's something. I think it gives hope to the patients and to all of us.
Yeah, and I just think it's really important. I think, Cole talked about this too. These are off-label uses, and just make sure that you document that. I always have that discussion with the patient and I make sure it's in my documentation. So, all right.
One question I had after last week, where she showed the risk reduction from people getting the shots and building up a depot effect and not dying of fentanyl, but that wouldn't protect against wooden chest, or does it?
That is a fabulous question. But the Suboxone wouldn't either.
So, I mean, it was a good strategy, but it's definitely not 100%.
No.
Right. Yeah, that's a good.
Correct me if I'm wrong, but in addiction, is there anything that's 100%?
Medicine in general.
I'm hoping there's something, but so far I haven't found it. I keep looking. Yeah.
100% of our patients will die eventually.
Yeah, but that's about it.
I think 100% is a positive pregnancy test, like legit. You're either pregnant or you're not.
Yeah, that's true.
Oh, that's interesting. We'll make Beth look into that one.
Yeah.
Yeah, Abby can stay on a second or about the prior auth thing, and we can probably even maybe connect you with Brittany offline about getting Sublocade covered. And that whole process, because I was surprised at how fast the prior auths were going through for Sublocade. Than what I was expecting. So we can definitely discuss that too. But
Elizabeth just lit up. Beth, do you have something you wanted to say before we go?
I wanted to ask her that question about that.
Okay.
Patient.
All right, everybody, we will let everybody go. Cole, that was fabulous. Again, every time you come on, we get great discussion, and that was those things really brought it out. So thank you so much. And we hope to have you back a few months down the road and once you get settled into your spot over in Duluth. So
sounds good. Thank you, guys.
Yep.
Yeah, thank you.
Yep. Thanks everybody for coming. We'll see you next week.
Hey, Cole, do you have just a second? I had a mortality question, if we have a minute.
Yeah.
So what do you think the causes of mortality are for acute, for patients with just stimulant use disorder? I think of opioid use disorder, that's explainable, the methamphetamine and opioid combination.